You will remember from anatomy that the main components of the conducting system are the sinoatrial or SA node, situated near the entry of the superior vena cava into the right atrium, and the atrioventricular or AV node leading into the bundle of His, which then divides into the right and left bundle branches in the interventricular septum. During each cardiac cycle, the atria contract in diastole to fill the ventricles, which then contract during systole to supply blood to the lungs and the systemic circulation. Contraction of the atria and ventricles is tightly coordinated by a wave of depolarization spreading through the muscular walls of these chambers. The depolarization wave, seen here in blue, reflects movement of charge across myocyte membranes and is in effect an electrical current spreading through the heart. Following systole, cardiac muscle returns to a resting state, and this is associated with reversal of the movement of charge across the myocyte membranes. This second wave of electrical activity, seen here in red, is termed cardiac repolarization. The leads of the ECG machine are designed to detect and record these two waves of cardiac electrical activity. The depolarization wave spreads through the heart in a highly predictable pattern, and to understand the ECG readout, the pattern of spread of cardiac depolarization needs to be understood. Cardiac depolarization is triggered by an electrical pulse generated in the sinoatrial node. This electrical pulse then spreads through the atria, triggering their contraction late in diastole. The atria and ventricles, however, are separated by a non-conducting fibrous septum. The depolarization wave cannot penetrate this barrier, and in order to activate ventricular contraction, the wave must be transmitted into the ventricles by the specialized cardiac conducting system. In a normal heart, the only route by which the depolarizing wave can enter the ventricular conducting system is through the AV node. In order to allow the ventricles to fill with blood following atrial contraction, the AV node initially delays the spread of the depolarization wave. And after this short delay, the depolarizing signal is transmitted into the ventricles via the bundle of His. The bundle of His lies in the interventricular septum and divides into right and left bundle branches. The right and left bundle branches transmit the depolarizing signal into the muscle mass of the right and left ventricles respectively. We should note at this point that the interventricular septum is the first part of the ventricular muscle mass to depolarize, and it does so by movement of current across the septum from the left towards the right bundle branch. We'll see later that this early left to right movement of current in the septum is crucial to understanding several important ECG abnormalities. As septal depolarization is taking place, the depolarizing wave begins to spread rapidly through the bulk of the left and right ventricles. As you can see here, in the walls of the ventricles, depolarization spreads from the terminal fibers of the conducting system outwards from the endocardium towards the epicardial surface of the heart, and also back along the ventricular wall to the atrioventricular groove. The final piece of muscle to depolarize is the upper part of the interventricular septum, and again this occurs by movement of current from left to right. Cardiac repolarization is not truly propagated between cells. However, cardiac myocytes repolarize at different rates depending on their anatomical location within the heart. Within the ventricular wall, there is a gradient in the rate of cellular repolarization. Cells in the epicardial region have the fastest rate of repolarization and repolarize first following ventricular contraction. The rate of cellular repolarization is then progressively slower as we move from the epicardium towards the endocardium. Therefore, perhaps counterintuitively, repolarization spreads through the ventricles in the opposite direction to the depolarization wave. As illustrated here, repolarization begins in the epicardium and then spreads backwards from the epicardial to the endocardial surface of the ventricles. We'll see later that this retrograde spread of ventricular repolarization is important in understanding the normal ECG readout.
During atrial fibrillation, the atria contract very rapidly and irregularly. This happens when the electrical signal begins in a different part of the atrium than the SA node. Abnormal electrical signals tend to begin in the left pulmonary veins, rather than the SA node. Atrial fibrillation also can happen if the signal is conducted abnormally. The abnormal electrical signal causes the walls of the atria to quiver rapidly, or fibrillate, instead of contracting normally. As a result, the atria don't work efficiently and don't pump all their blood into the ventricles. If all the blood does not flow into the ventricles, the blood that remains pools in the atria. If blood pools in the atria, clots can form. This increases the risk of stroke because part of a clot can break off and travel to the brain. During atrial fibrillation, the ventricles continue to contract from the heart's electrical activity. However, the abnormal electrical signal traveling from the atria through the AV node make the ventricles beat faster than normal. As a result, the ventricles don't pump blood efficiently. This can lead to heart failure, a condition in which the heart cannot pump enough blood to meet the body's needs.
When the heart is injured, the heart cells become irritable and cease to contract in rhythm with the normal cardiac rhythm. The result is extra beats. If the extra beats become frequent, there is a complete loss of coordination of contraction of the heart muscle. The result is the inability of the heart to pump blood to the body, resulting in death.
Here is the second-degree heart block type 1, also called Mobitz type 1 or Winky-Bach. The unique characteristic of this normally benign block is a progressive lengthening of the PR interval until an atrial impulse is not conducted through the AV node. The problem is with the tissue in the AV node and is usually transient. The AV node is diseased, it gets tired quickly and can't do its work, and after a short period of rest it can pick up and conduct the impulses down again. Other than the AV node needing an occasional rest, the conduction process is normal. Here is second-degree heart block type 2. In this rhythm, the PR interval is consistent, unlike the progressive lengthening PR interval with the type 1 heart block. Like type 1 heart block, there is an occasional beat not conducted, and the problem again lies with the AV node. But the possible complication with this block to complete heart block makes it a much more serious situation. Type 2 heart block is caused by damage to the AV node from disease or ischemia. Here is third-degree heart block, also called complete heart block. The unique characteristic of this rhythm is the dissociation of atrial and ventricular conduction. There is no PR interval. The atrium is firing at a different rate than the ventricles. The atrial rate here is about 60, and the ventricular rate is about 30. The AV node is damaged and cannot conduct impulses from the atrium to the ventricles. Luckily, the ventricular Purkinje fibers have dormant pacemaker properties which come to life when not overridden by the faster sinus beats. In this unique situation, there are two pacemakers firing simultaneously, the sinus node and the ventricular Purkinje fibers. This situation is serious because if the ventricular Purkinje fibers do not pace as expected, then the heart goes into ventricular asystole, resulting in death. Ventricular tachycardia, like supraventricular tachycardia, is often generated from a re-entry pathway. When the re-entry pathway is innervated, it initiates a pacing impulse which rapidly fires off the cardiac muscle. A ventricular rhythm faster than 100 beats per minute is termed ventricular tachycardia. It's important to note that ventricular tachycardia can be relatively stable or unstable depending on the rate and condition of the heart. It's not uncommon for a patient to walk into ER complaining of a fast heart rate, only to find them in ventricular tachycardia.
In supraventricular tachycardia, or SVT, the irregular electrical impulses pass across the ventricles and back up into the atria in a circle, rather than travelling from the atria to the ventricles in one direction as they should. This makes the heart beat faster.